Perfect. Well, I have 8 o'clock there. So with that, we will go ahead and start this month's Journal Club, which is brought to us by ASJ and the Next Generation Editors. And it's the first ASJ Journal Club of 2022. So thank you everybody for taking time out to join us tonight. My name's Ryan Austin. I'm a plastic surgeon in private practice in Toronto, Ontario. I'm the lead of the Next Generation Editors. I'm going to be moderating tonight's session, and we're joined tonight by Dr. Andrew Weinstein, who's one of our fellow co-Next Generation Editors in practice in New York City, who's going to be our discussion curator. So if you have questions, if you have any comments as the session goes on tonight, make sure you open your chat box, comment, and ask questions of our discussants. We will be sure to get to those and answer as many of the questions as we can. There's also going to be poll questions that will be popping up, so make sure that you answer those so that we can keep track on what people are doing in their practices when it comes to soft tissue fillers. So tonight we are going to be reviewing a special topic article from the January 2022 issue of ASJ entitled Aspiration Before Tissue Filler, an exercise in futility and unsafe practice, and its accompanying commentary article. We're fortunate tonight to be joined by one of the co-authors of this month's selection, Mr. Eqram Rahman, who is joining us tonight, or more accurately, the wee hours of tomorrow from London, England. Since receiving his undergraduate degree in medicine, Mr. Rahman has gone on to complete a master's degree of surgery, his PhD, as well as a master's of surgical education. Mr. Rahman is currently a professor in plastic surgery at the Royal Free Hospital at University College London. In addition to his clinical and research work, Mr. Rahman has established and led many postgraduate surgical programs across leading universities in the United Kingdom and is regarded as an expert in graduate medical education and training. Mr. Rahman currently serves on the editorial board of ASJ as the evidence-based medicine section editor, and we're very thankful that he stayed up late to discuss his article with us tonight. So thank you very much. We're also lucky to be joined by two co-discussants for tonight, also from our ASJ editorial board. First up, we have Dr. Ivona Percec from Philadelphia, Pennsylvania. Dr. Percec completed her MD PhD as well as her residency training in plastic surgery at the University of Pennsylvania. Dr. Percec subsequently joined Penn Medicine in the University of Pennsylvania Health System, where she acts as Associate Director of Plastic Surgery, the Director of the Basic Science Research Program in Plastic Surgery, as well as the Medical Director of the Skincare Program. In addition to her clinical work, Dr. Percec also runs the Percec Anti-Aging Lab with a focus on studying the impact of stem cells in the aging process, scarring, as well as their role in facial and body rejuvenation. Dr. Percec's a member of the editorial board, as I mentioned, as the research section editor. So undoubtedly, she'll have some great insight and expertise to share with us tonight. Joining us as well is Dr. Julius Few from Chicago, Illinois. Dr. Few received his medical degree from the University of Chicago Pritzker School of Medicine and completed his residency in general surgery at the University of Michigan Medical Center before his plastic surgery training at Northwestern University. In addition, Dr. Few undertook further subspecialty training in facial and eye cosmetic surgery in Honolulu, New York, and Atlanta. Dr. Few serves as a clinical professor in the Division of Plastic Surgery at the University of Chicago and is on staff at Northwestern University, also serving as a past president of the Illinois Society of Plastic Surgeons. Dr. Few is on our editorial board at ASJ as the cosmetic medicine section editor. And so again, his expertise and insight will be invaluable for all of us who have tuned in tonight. Well, I know that when an introduction takes that long, we're in for a great session and lots of knowledge and expertise to be shared. So without further ado, I will hand the controls over to Mr. Rahman for his presentation and article.
Thank you, Dr. Austin. And thank you so much for inviting me to present the paper, which was published in late 2021, Aspiration Before Tissue Filler, an exercise in futility and unsafe practice, with 12 other co-authors, namely Professor Greg Goodman, Mark Magnuson, Peter Callan, Stephanie Roberts, Sarah Hart, Frank Lin, Cara B. McDonald, Stephen Liu, Kath Porter, Nima, and Michael Clegg. This whole paper was ignited by an article published in 2021 ASJ, the descriptive analysis of 213 positive blood aspiration cases it was followed by our letter to the editor. So I would really request all the participants to go and read these two interesting articles. Now, the importance of aspirations predicted on the following structural concepts. And we all know that the cannula is placed in the desired positions. And once it's in position, we perform the aspirations. Depending on the aspiration result, whether positive or negative, we put the filler placement. There are many beliefs and concepts regarding aspirations of filler, aspirations before filler placements. And when we thinking of writing a paper, we looked into the evidence that supports that beliefs and concepts. I'm not going to talk about all the points that we described in the paper, but few of the importance are number one, quick pull aspiration test on the plunger sufficient to ensure safety of injections. We found no compelling evidence to support that. Not only that, not only quick, the slow pull also doesn't have enough evidence to suggest that it will give false, true positive aspirations. Then we went on to great details on talking about understanding the anatomy, is whether it's sufficient for filler placements. Also, we talked about the vertical injections onto the periosteum, whether it's safe, and also the priming and non-priming of the needle. So I have divided the whole paper into some assumptions and arguments that we presented in this paper. So the first assumption that we presented on this paper is the cannula or needle must be placed in the desired position for injections and not to be moved at this point. Now, when we place the cannula or needle in a desired position and ready to aspirate, one cannot perform the both of the technique together. It will cause 0.5 to 1 millimeter displacement of the needle or cannula tip. The second assumption was one must deliver bolus precisely in that position. But since there is a movement of the needle tip or the cannula tip, you cannot rely on the previous
right now. I saw your call.
placement of the needle or cannula position.
Good.
Then the next important assumption is, if you believe such that you shouldn't move when you place your needle or cannula, and if you practice such, you cannot apply to all the regions of the face. Say, for example, the mobile regions of the lips, and it's thoroughly impractical and if not impossible to aspirate and stay still in every single injection point. It is a commonly accepted fact that one should reach the periosteum and settle there and perform aspirations. Of course, this only works when there is a periosteum at the injection point. This is not possible in most of the periosteal area and not desirable over the bony foramina. And we found that at least 5 cadaver studies suggest that periosteal needle placement may not have accuracy of the placement that has been assumed. Next assumption on our paper was both of the needles and cannula are capable of piercing the blood vessel and initiating embolism. And once it happens, following an intervascular scenarios may occur despite perceived periosteal safe placements. Now, there are few scenarios. Number one, in this picture, an impacted blood vessel may be dragged into the periosteum, and once on the bone, the vessel can easily be punctured and filled with hyaluronic acid filler. In this instant, there would be a possibility of a positive aspiration test. So both of the needle and cannula are capable of piercing the blood vessel and initiating embolism. And once this has happened, the following intravascular scenario may occur despite perceived periosteal safe placement. Following that, the second possibility is that needle may have skewered and passed through a vessel, leaving a tract of low resistance alongside the needle extending down to the bone. And what will happen is this will allow filler to spread along the low resistant tract back into the impelled vessels, and positive aspiration scenario is most likely. Now, following from the same assumption, the third possibility is that the length of the needle bevel may induce an unexpected intravascular injection, even with a periosteal needle positioning. As you all know, that for a 25 gauge needle, the bevel length can reach up to 2 millimeters. And in cadaver studies, it has been shown that vertical needle placement have been shown to allow filler to go into many layers, especially the middle or muscular lamella. Assuming the same fact that needle and cannula capable of piercing the blood vessel, the fourth possibility is that the needle or cannula is blocked either by the wall of the vessel being sucked into the instrument opening, or the vessel collapsed during the aspiration maneuver despite being intravascular and flashback is prevented. So once in position, aspiration is performed, and the finding may be relied on to proceed or not with an injection, and that is the assumption. But with the available literatures and evidences, we have stated in our paper that neither the quick rapid pull or slow pull has enough evidence to substantiate that they will yield a true positive or a true negative result. Now, next comes down to the issue around negative aspiration as a safety maneuver. Now, insufficient negative pressure may lead to false negative aspiration, especially in the small vessels. Exceptionally quick pullback aspiration will have insufficient pressure for the filler column back into the syringe on aspirations. And it is possible, like I said before, and we stated in our article, that small caliber vessel may collapse under the pressure. And on Dr. Jewell's commentary, he rightfully commented that that 1 ml HA syringe approximately induces minus 165 torr, which is sufficient enough for a small caliber vessel to collapse. Now, assuming again, the issues around the negative aspiration as a safety maneuver, again, the vertical needle insertion may lead to multiple layer injections, as I stated above. And although large bore needles are considered to be beneficial for decreasing the false aspiration, the problem is with a longer bevel poses a potential problem due to the likelihood of entering into the multiple layers on vertical injections. We also talked about the priming and not priming of the needle. There are arguments on both sides, but still there is no evidence to suggest that priming or not priming of the needle will give you and authenticate a true positive or a true negative result. Before going into the recommendation of the paper, we just want to highlight a fact that that in recent morphological and topographical facial anatomy paper, it has been repeatedly stated and mentioned that although there is a variation in the major facial blood vessels, but there are more topographical and variations for medium-sized blood vessels in the face. And as you can see, this is a fantastic plastinated model of the face, and one cannot inject without vessel displacement and putting the filler onto the face. So is aspiration been recommended, or is it helpful to give aesthetic physicians a sense of safety that they are not within the blood vessel? It doesn't. So the recommendations were: understand the safest depth of the injection in any given area, inject very slowly with a low extrusion pressures, and cannulas are considered more safer, but small gauge cannulas can behave as a needle, and consider utilizing the local anesthetics, microbolus, micro movements, and also there is no evidence as to support that aspiration as a safety measure for filler placement. Thank you.
Thank you very much for that excellent presentation and review of an excellent article from the January issue of ASJ. With that, I will hand the controls over to Dr. Percec for her thoughts on this article and her comments. Oh, we've just got you on mute, so if we could just get you.
Can you hear me?
Perfect, thank you.
Very good, thank you, Ryan. And thank you, Mr. Rahman, for that beautiful presentation, and more importantly, for your authorship of this very important work. I'd like to start out with highlighting, as Julius probably will as well, the importance of this topic. And I think it's one that has been discussed and needs to continue being discussed, because our field is exponentially growing, as are injectors, and the safety parameters around injectables is going to continue to expand, and the more injections you do, the more likely a complication. And this article discussing the most extreme of complications, in particular intravascular injections of HA fillers, is really the most appropriate when discussing complications. I think the manuscript was very well written. It was very thoughtful. It was very logical, almost in a very classically philosophical manner. So it was actually, from a logistical standpoint, it was very, very refreshing to read in that sense, because we don't often have those kinds of publications. And I think that aspiration as a concept as conferring safety is often misunderstood. And I think it's critical that we highlight the important parameters around aspiration. And this article beautifully confers that and has described it in a way that I think other investigations have not. And it beautifully puts together the premises, the beliefs, and the concepts. I think in highlighting the importance of movement and bolus injection in relation to movement, it really highlights the most important components and why aspiration does not make sense as a safety measure. And I think that has to be highlighted for especially our novice injectors, for trainers, as many of us are. And that even though it's practical, the false sense of security conferred by aspiration poses a huge risk for a catastrophic event. And so that is beautifully highlighted in this paper. And I think that's one of the most important components. And obviously you can have a catastrophic event if the other parameters of safety are not followed that have been highlighted beautifully by Mr. Rahman in terms of anatomy, knowing the depth, etc., the injection, velocity, pressure components. Two of the other components that I think were very importantly highlighted by this manuscript were the periosteal or subperiosteal component of injections, and the dichotomy of the belief system of certain injectors believing that depth confers a high safety profile, versus what's been highlighted here is that if you inadvertently try to inject around the neurovascular bundles, that's obviously the area of potentially greatest risk. And the priming versus non-priming, I think, is also beautifully highlighted as a concept in this article in terms of importance. And I do have a few questions for Mr. Rahman, if that's okay, or would you like to proceed with Dr. Few's commentaries and we all do questions together?
Why don't we get Dr. Few's thoughts, and then what we can do is we'll loop back, and then we can ask some questions back to the author, if that works.
Absolutely.
Perfect. Dr. Few, take it away. I'd love to hear your thoughts.
Thanks, Ryan. I also want to applaud Mr. Rahman for really an excellent submission to the Aesthetic Surgery Journal. As a section editor for cosmetic medicine, it's a real treat to see work such as this hit our journal. I also want to congratulate Mark Jewell for his thoughtful commentary. I think a number of technical points for anybody who doesn't know Mark. He is one of the more technical thinkers in our field, and I think really presented some useful material as well. I could not agree more with what Ivona said. I think that this is a critically important piece of work. We are seeing a number of articles that are coming through that range from anecdotal aspiration, various authors actually putting down in their manuscript that they aspirate, even though they know it doesn't mean a true or false positive versus negative. And the reality is, I think many of us, especially with this data, showing data such as 53% positive aspiration when you're looking at drawing back on a pigmented dye. It's very telling. I think it's also important to note that every manufacturer and every syringe, when it comes in the given packaging, it varies. So depending on the interaction between the hub interfacing with whether you're using a needle or cannula, and the actual syringe design really impacts that data as well. So aspiration may be even less significant depending on which product. I'm not going to pick on products, but I've played with a number of products using this simple test, actually drawing back a semi-viscous material, and I've seen it less than 10% that you could actually draw back. So I think this is a really important thing. I also feel that the points highlighted in terms of actually aspiration relative to micro movements, and in some cases more macro movements, I think is really an important point, because you could literally have somebody place their needle or cannula at the right level, they draw back and they're in a more superficial plane, and now they're actually intravascular. So I think this is something that has been well described, and as somebody who has seen referrals of different patients who have had embolic events, a number of those cases they actually aspirated. So I think it's really an important point that is highlighted here. The one thing that I didn't see as much highlighted, but I do think is really important as a reminder, is those patients who have had prior facial plastic surgery. This is really, really important, because when you have a cicatricial change to the tissue where the vascular anatomy is less mobile, that's where you're at super high risk. And I've seen expert injectors who have reported actually intravascular events in a case where there's no way they would have gotten into that issue. So I think that that's a really important thing, that all the rules kind of change when we're dealing with somebody who's had previous facial cosmetic surgery in particular, or even reconstructive surgery, that anatomy has changed. The last point I want to make is that I really feel that kind of going in line with understanding the anatomy, that it is important to look at depth of placement, because obviously one of the biggest areas that we've really learned this lesson is in the glabella. So if we look at injection in that anatomic area as an example, really this is an area where we really have to think about the vasculature in terms of what level in the soft tissue it's running, and then working back from there. So I think much more should be, and to quote Claudio Di Lorenzi, there is no such thing as a safe injection. Our goal is to make as safe an injection as possible. And I honestly, even though I've been doing this for a long time, I inject as if every time I'm working around vessels, and I get definitely my coronaries are kicking harder, because I don't want to ever assume, no matter what, that I'm in a vascular free zone. So I think that's really important.
That's excellent. Thank you so much for that. Dr. Percec, I know you had a few questions to pose to Mr. Rahman, so I will let you go ahead with those. We'll just get you back off mute there if you wouldn't mind.
So I think what's been highlighted by both the presentation as well as Dr. Few and my comments is that there's a huge number and probably an increasing number of variables as we go along with injectables in terms of that can be controlled to do an assessment such as a safety-based assessment on aspiration. And so the thought is, can we design, and why hasn't there been designed, an animal model that's reproducible and so can really simulate different areas of the body, different depths of injection, and then we can apply all of those variables in a very consistent and reproducible manner, and in addition be able to continue to include novel products as they get brought onto the market and kind of incorporate them into that paradigm as we go along. And I don't know if it's funding that's of concern, and so it would behoove all of us to try to get perhaps an animal model funded for this purpose. So that's the first question I have for Mr. Rahman in regard to this.
Oh, thank you so much for this question. As a passionate clinical anatomist, I think I tried with the aspirations from the cadaver to initiating extracorporeal circulations for assessing the aspirations technique. The problem with the animal modeling, say for example mouse or rabbit, is the tissue integrity of the face and the subcutaneous tissue depth of the rabbit and or the mouse model. They are not compatible. And also the vascular integrity of the face and the vascular integrity of the traditional used animal model, also they don't match. It would be great to explore an animal model to replicate the actual aspirations and with a different non-Newtonian fluid, which is not only HA, but also other product. But I absolutely agree with you. We have a lack of a sustainable animal model to explore a benchmark research to investigate on the novel filler techniques or the non-Newtonian properties of this. Absolutely.
Thank you. Thank you. I completely agree with you, and maybe we can brainstorm and figure out a potential solution. I understand the translational component from an animal in terms of anatomy may not be obviously in a facial anatomy will not be easily translatable, but perhaps using other body parts would be amenable to a good start. Another question I have that's more specific to your articles, can you highlight to us, how did you decide upon the table of beliefs and concepts? How did you select those 10 beliefs and concepts to discuss? Were they highlighted through the papers? And in relation to that, or in is how did you include or exclude papers based on the discussion with other authors?
Dr. Percec, it's really important question, and thank you for this. So the idea with Professor Goodman is to start a systematic review first. But the problem with a systematic review is that most of the study is is a perception study. So, and the bench research study. So one cannot be compared with another. If we want to execute a systematic review and comparing the and doing the evidence synthesis using a critical appraisal technique. So we looked into all the methodological flaws and strengths and weaknesses, but we thought that the best way to do this is just a literature review, but we will do it as an integrative literature review. There are many integrative literature reviews now, and the strength of the integrative literature review is we don't exclude any papers. We include all the papers, and we try to explore the main theme of the paper. So the paper that we have selected and mentioned it on the table, we selected the major theme emerging out from this paper, and then we proposed our finding or likely to be proposed on that table. So basically, we didn't exclude any papers, and it is an integrative literature review. We found, I think, 23 papers, and then we explored the major theme. Although there are a couple of themes in individual paper, but we try to extrapolate the major theme, and then in another column, we thought that we will state our argument, and then in the discussion section, we will elaborate them.
Very good. Thank you.
But I would say just one thing. There are 2 centers in UK now. Now we are working on the artificial skin modeling, and the artificial skin model will have exact vascularity with thickness. So once we have a substantial big area of the artificial human skin with the blood vessel, I'm sure that we can come out of the animal model, and hopefully we can do our bench research on these human skin samples.
That would be wonderful. That would be a huge foray forward, as would be the control of the animals. If we could do that for the humans and vice versa, that would be yet another level of translatability, but that's yet to be determined. I will defer to Dr. Few to see if he has any questions.
I think that your points were extremely well taken, Ivona. The only question I really have is your thoughts, Mr. Rahman, about syringe and needle design. Is there, in your review, did you find anything that would consistently predict an ideal design across manufacturers? Because there is such a, it's such a heterogeneous population of technology from one syringe to another. Is there a recommendation that we should be sterilely transferring product to a particular syringe to allow for a safe aspiration, if there is such a thing? I mean, I think that's kind of, I'm piggybacking on really the previous question, but perhaps you have a perspective on that.
Thank you, Dr. Few. Again, because it's an integrative literature review, we try to look into the reporting in previous bench studies and previous observational or perspective studies. Unfortunately, we couldn't find, rather than just reporting the outer and inner diameter of the vessels or the beveling length, we couldn't find any recommendation as such or preference towards one needle or cannula. But there was only one study. This was not a study. It was actually a manufacturing promotion by Tioxan. And what they did, they used all the filler injections available, and they compared it. They compared with a slow pull and a rapid pull. And then they come up with their automated injection machine. We excluded that paper, not a paper, we excluded that report only because we thought that it will pose a bias. And it was just one industry comparing 27 syringes, and most of the manufacturer, they said, oh, it's a false positive, false positive, false positive. And the sponsor companies, the syringes, they said that it is much better, but we also we are developing an automated device. So I thought there was an inherent bias to it. Sure. But you rightfully, I think, highlighted a very important point that future research should explore more onto the designing the needler cannula mode.
Excellent. Well, hopefully your group will participate in that, because you're certainly doing dynamic research, which I applaud. So,
thank you, Dr. Few.
Fantastic. Before I ask a couple of questions and we get on to the poll results, I'd like to actually invite Dr. Jewell, who's the author of this month's commentary. He had a lot of excellent points and an excellently written and well thought out commentary. Dr. Jewell, do you have anything else that you would like to comment or add?
Well, thank you. You know, actually, I'm sitting here with my daughter, Hillary, who's our nurse practitioner and expert injector. And, you know, again, I think it's important to have science and data to base up practices. And, you know, if this is an unsafe practice, it doesn't give us certainty that we are extravascular or intravascular. Don't do it. You know, it's time wasting, and you know, again, it does not accomplish its intended purpose. I just reviewed another article which was ultrasound looking at needle movements, both novice and expert injectors, and you know, the needle can move during aspiration up to 5 millimeters. So you can get yourself into trouble by trying to pull back on the plunger and not, you know, not keep the needle in the same spot. So, you know, again, I think we know where there are danger zones, piriform fossa, areas like that, angular artery. You know, we should know to stay away from them. At the same time, as Claudio De Lorenzi says, there's no safe injection. So, you know, do informed consent, talk to your patient, be safe. And, you know, there are lots of patients that get tremendous benefit out of cosmetic injectables. At the same time, in my discussion, you know, a very aqueous solution like the neurotoxin I was injecting, I actually got that intra-arterial once upon a time, and then had the needle, you know, flash back into the hub of the syringe. So, you know, with less viscous material, sure, you may be able to determine if you're intravascular, but not with the current generation tissue fillers.
That's great. Thank you so much.
Thank you.
Dr. Few, I'll ask you a quick question. For some of our younger injectors, or, you know, residents or fellows who may be tuning in or listening to this journal club, in Mr. Rahman's article and in this group, they talk about angle of approach, trying to take an acute angle with the skin, trying to keep the bevel down towards the periosteum. What tips for injection technique do you have that can try and help, as you say, you know, we can't ensure safety, but to try and maximize safety and minimize potential complications when it comes to actual injection technique? Can you share a couple pearls?
Sure. You know, I think the biggest one is once you assume the reality that there is no such thing as a fail-safe option. I am, and you know, I've certainly published this, but I'm a big fan of microcannulas, but with an emphasis on macro. I tend not to go than 5-gauge cannula. Back in the days, I was a 7-gauge cannula, and subsequent tested that gauge the best as a needle. You okay? Can you hear me?
It may just be me, but I was losing my connection there a little bit, and I'm getting some nodding heads. So I have a frozen video of Dr. Few. So maybe what we'll do is we'll come back to that question. We'll just see if your screen can unfreeze here in a second. Maybe I'll pose this. I'll pose the question to Dr. Percec just while we've lost Dr. Few. Same question. What pearls do you have that we can try and maximize safety when we're doing injectables for the young injector, or maybe even as we're teaching injections, or for ourselves?
Absolutely. So I agree with what's been said, is that basically there is no such thing as a safe injection. And those who think that by knowing even the anatomy, even the depth, and even the aberrant anatomy and vasculature, if that kind of knowledge base is sufficient, it's not sufficient. It's never sufficient. So I teach my residents that you have to remain humble. That doesn't mean that you have to be scared per se, because that'll cause your hands to shake. So that's not very good either. But just a humility of looking each time you inject, obviously knowing your anatomy, knowing your depth, understanding that if you inject on one area of the face, it can cause an ischemic event on the opposite side of the face in a totally different area, because the systems are interconnected, obviously. And looking at all of those parameters as you injecting slowly, using the right product, the depth, and really assessing the entire trajectory of where you're injecting, not just that one spot. And if you see that you're getting a mini hematoma, you have to stop injecting. It's common sense. We know that from a volume standpoint. So if you're injecting the infraorbital hollows, not only are you concerned about the product migrating potentially into a vessel, but you know that your volume displacement from the hematoma itself is going to confound your results because you don't know if that volume is from the bleeding or from the product itself. So teaching the residents how to dissect out all of those variables, and that there is, this is a very complicated process that requires humility. Even though it's a needle and it's not taking a saw to the facial skeleton, which is the opposite end of the spectrum in terms of invasiveness, you have to have just as much respect for the needle as you do for a scalpel or a saw or anything that is greater. And in fact, probably more so, because you're doing more of these procedures on more patients and you're using more needles. And also, I would say reading articles such as this and keeping up with the literature is really critical as one does this.
I am so sorry. I don't know what happened to my internet, but anyway, I don't want to prolong the journal club. So Ivona, what did I interrupt?
I answered the same question. And my suspicion is you are going to respond in a very similar manner on how we train our residents. And I spoke a lot about humility and maintaining humility with the needle, just as you would with an operation. So it's not just about knowing the anatomy and injection technique, but also observing the trajectory of where you're injecting and really being a very conscientious and conscious injector and not taking it for granted.
No, 100. I obviously, as you said, I 100% agree. And the point I started to make before things glitched was just the idea that we should avoid, in my opinion, using a cannula if you're a fan of a cannula that's smaller than a 25 gauge. The reality is nothing, again, is 100% safe, but I am a fan of a micro cannula with rare exceptions, that a couple of them being, for example, treating the chin, treating the cheek, the forehead. Those are really sites where I do like to place on the periosteum. I think the points that were made in the paper, and certainly Mark Jewell has made these points in various publications he's authored, slow injection, not large bolus injection, And at the end of the day, knowing the anatomy. And again, I can't say it strongly enough, caution in those who have had surgery. I can't tell you how many times this has come up as an issue, even with expert injectors.
And one question I'd like to ask, I know we're getting close to the end of the Journal Club session. I'd like to pose to Dr. Percec, Dr. Few, and actually Dr. Jewell is a former president of the society. How do we, as plastic surgeons, we're a shrinking portion of the number of people who are injecting these products. And we're the ones who are reading this literature. Obviously, we're the ones publishing this literature in our specialty. How do we get this word out to change this kind of concept, or this snowballing idea that aspiration is a tool, or that we should be aspirating and putting large volume boluses and doing this when we're a shrinking voice in here? How do we make an effective plea to try and ensure patient safety, or to, again, maximize patient safety?
That's a very important point, Ryan, and I think it's going to continue to become more so with time as our injector base broadens and expands beyond surgical injectors. And obviously dermatologists are probably the largest fraction of injectors. I think it's very important to do several things. Number one is collaborate with both the lay media. And I'm not talking necessarily about social media. I'm talking about, at least from University of Pennsylvania, we have many resources where we connect with the public in terms of patient education. Same thing for injector education. I always encourage medical students, whether they're interested in plastic surgery or not, dermatology students, any kind of non-plastic surgery trainees to come and join me, because as much as we would like to maintain the safety by limiting the injectors to, let's say, a surgical or sub-surgical specialty, that's not the reality. So I fully believe that educating them as much as possible is only going to maintain our position as really the foremost experts in all depths and levels of anatomy. And I think that's who we are as plastic surgeons, because we are the only ones who understand the bony anatomy, the soft tissue anatomy, and the skin anatomy. So it behooves us to be the educators. So I think it's really important to keep an open mind and to educate all sorts of injectors, because that is being realistic, and that's going to maintain the safety of our field as well as our own reputation as educators.
I'll piggyback on that. I think that this is a ripe and unique opportunity to share this data with industry. Industry has the strongest voice. Obviously, we are seeing exponential growth in injectors that are more or less delegates. And even, certainly in Illinois and in California, you see a record number of free agent injectors. They may be nurses, they may be nurse practitioners. We're dealing with various laws now around just autonomy. So instead of making that a political argument, I think just being able to deliver hard data to industry with the emphasis on sharing with their injector base, I think would be the most significant viral way to get the information out. Fortunately, the Aesthetic Surgery Journal is the go-to journal for industry. And so I think this is an easy place to start. I also think, and this is something Mark started a long time ago during his presidency, injectable safety, which I was fortunate to play a small role in. But it's an opportunity to call on our derm and facial plastics colleagues as well, to have them amplify this. So those are my thoughts.
Yeah, no, I agree with you, Julius. When I founded the Physicians Coalition for Injectable Safety 17 years ago, we disseminated information back and forth. We had a workbook, and stuff like this is useful in peer-to-peer for core trained injectors. And I also second your idea of working with industry here to help them understand what is the state of the art in terms of injectable practices here, and to avoid stuff that doesn't add knowledge to where the needle is and or safety. So I think it's a two-pronged approach here, and this webinar tonight, Ryan, is fabulous. I hope that we can share this with colleagues and build bridges back to dermatology, dermatologic surgeons, facial plastic, oculoplastic, and also the international group will work well.
Fantastic. That's great. And the nice thing is, if you have any colleagues, we're going to be making this available on YouTube. It's going to be available through the website. So make sure that you share it, get the link out, and we want to have as many people reading this research, seeing this research, and learning from this research so that we don't silo ourselves. With that, we're coming to the end. I'd like to hand over just to Dr. Weinstein for a quick review of the polls that we had to see an information of little status of where people were at coming into the session and where we may be leaving before we let everybody go for the evening.
Thank you, Ryan. Good evening, everyone. Thank you for completing our surveys this evening. We were joined by a majority of respondents from North America, as expected. 10% are from Asia, and at least one individual from Europe. About half of us perform injectables daily, and most perform using a combination of needles and cannula. 15% use exclusively a needle technique, and none exclusively using a cannula technique. Almost 50% of respondents use a 27 gauge, either needle or cannula, which is interesting because at that 27 gauge threshold, that's when the cannula acts like a needle that studies report as associated with risks of intravascular puncture. In terms of techniques used for soft tissue filler injections, over 50% use a combination of static bolus techniques and moving fanning techniques. And it was almost equally split in terms of aspiration. 22% always aspirate, 39% sometimes aspirate, 17% rarely aspirate, and 22% never aspirate. So that's really interesting. I think that this study really sheds light onto that this is something that we as clinicians do in a very different way. Unfortunately, in terms of the last question, almost 100% of respondents never use any imaging technologies when injecting, which I think is a really, it's emerging as an adjunct to injections. And I know of clinicians who are using it. So it'd be interesting perhaps in a future journal club to discuss imaging, especially considering that after this one, we're not injecting in a static way, but moving it. So what's the role of imaging? And then lastly, in terms of whether this journal club has altered your view on aspiration, over 70% said yes. So I think that it was very clinically valuable. Mr. Rahman, I just want to thank you for a great presentation and congratulate you on a great article. A question that I have for you, we talk about diluting fillers with lidocaine or another maybe saline for purposes of more uniform distribution. Do you feel that there's a role for doing that for the purposes of safety when injecting using a recommended cannula technique so the viscosity is lower, perhaps decreasing the amount of filler that enters a blood vessel during inadvertent puncture?
Oh, Mr. Rahman, you're just on mute there. Quickly, we'll just get you off for a...
Sorry, I think we need to understand that the filler material is not a Newtonian fluid, it's a non-Newtonian fluid. And normal saline lignocaines, they're all Newtonian fluids. So if you mix them and you want to place them, they will act differently. So function of the Newtonian fluid, like normal saline or lignocaine, won't interfere with the functions of the non-Newtonian fluid, which is HA. So I personally believe that going back to the physical property and physics, using non-Newtonian fluid and Newtonian fluid, we are completely denying the physical property of the individual materials. And I don't think it will cause any difference to how the filler functions.
Thank you so much. I see Dr. Nahai has a hand up. We will throw to him.
Good evening, everyone. Good morning, Professor Rahman. I really want to thank you not only for submitting your great work to ASJ. As Julius Few said, he loved seeing it. You can only imagine what the editor felt like when that paper came in. Beyond that, seriously, at 1 a.m., dressed so elegantly and speaking so eloquently, this has been incredibly educational and informative. Just wanted to thank you, thank Ivona and Julius, and of course, Mark, Jewell, and especially Ryan for putting it all together and somehow convincing you to join us this early in the morning. So I don't have any questions or comments beyond saying that I feel this paper was timely. I felt that this myth needed to be put to rest. And just to tell you how beautiful the article is, the artwork by the well-known Australian medical illustrator just adds to the paper. I couldn't agree more that we should be disseminating this paper. I saw that Professor Kumar is also on, and I know that he has heard the entire discussion, and I'm sure he would be instrumental in disseminating the great information in this article. So thank you, everyone.
Professor Nahai, I have a comment to make, and to everyone, that yes, this discussion is important, and promoting evidence-based practice, what Dr. Jewell said, Dr. Percec said, and Dr. Austin. But if you look at this side of the world, most of our trainee doctors, they're coming out of their core training program and going into aesthetics. So they don't have the knowledge of dermatology. They don't have the knowledge of plastic surgery. They're completely relying on ad hoc training services for Botox and fillers. Do you agree with me that unless and until I call this aesthetic medicine specialty in transition. So unless and until do you think there is a chance of forming a subspecialty in aesthetic medicine where you can support those trainee doctors to provide more evidence-based training program?
I couldn't agree with you more. There is a need for it, and all of us have a responsibility to do that. I'll put Dr. Andrew Weinstein on the spot. He did a fellowship with us, and I'd love to have him comment about what he knew about injectables coming into his fellowship, and how much more, or dare I say, did he know a lot more when you finished your fellowship?
Hi, Dr. Nahai. So with regard to that, I think that the first important point to make is really the respect for the anatomy, knowing the anatomy. It's sort of one of those things, non-surgical, I think is thought to be safer than surgical, but in many ways, the injections are blind. I mean, we talk about potentially using ultrasound or other imaging modalities, but without confirmation, visual confirmation, and we're discussing here aspiration is not one of them, that becomes very hard. And so techniques, learning from incredible mentors who have been performing safe injections for a long time is invaluable. And you know, I feel that everything I learned last year is proved so important now in practice. So thank you, of course, for everything.
Well, listen, with that, we've reached the top of the hour, and I'd like to respect everybody's time, everybody's night. I know Mr. Rahman probably has to get to bed. It's the middle of the night in London, and you know, I'd like to thank all of you for coming on, for your excellent article, Mr. Rahman, for Dr. Percec, Dr. Few, Dr. Jewell, and Dr. Nahai for their thoughts, for Dr. Weinstein for his discussion curation. Really, the reason that we do this is to take these important articles, to pull them out of the pages of ASJ, to bring them to life, and to see something like 70% of people reconsidering the way that they practice based on this session. I can only imagine what magnification that we'll see if we can get this out and get the word spread to our colleagues, to our friends. So the more that you see this, the more that you know about it. Share the YouTube link, direct people to the site, direct people to these journal clubs. Next month, Dr. Mark Albert is going to be running the Young Aesthetic Plastic Surgeons Journal Club. So make sure that you tune in, register for those sessions. Thank you all for taking time out of your nights and joining us. Stay safe and healthy, and we'll see you back next month.